We are on MCA TV at Gens Congress 2019. We are with Professor Ola Saugstad. Welcome, Professor Emeritus as a Division of Pediatric and Adolescent Medicine at the University of Oslo and Adjunct Professor at Northwestern University in Chicago. Which are the main findings in oxygenation for preterm babies at birth?
I think that one of the main findings recently was that we were able to show in the so-called torpedo trial that babies less than 28 weeks would need some oxygen, extra oxygen in the delivery room, provided they need ventilation. So that is one important finding. Another important finding is that it seems that the outcome of preterm babies less than 32 weeks is not as good as it could be if the saturation increases too slow. So what we have shown is that babies who reach a saturation of at least 80% within 5 minutes have a better outcome than those who do not reach saturation of 80% within 5 minutes. And this, I think, is now a very challenging topic in clinical neonatology, because we don't know how we should adjust the FiO2 to reach the optimal saturation the first minutes of life. Because there's a very short window where we can act, maybe only 1 or 2 minutes. So I think this is something we should emphasize in the next years. How should we adjust the saturation the first minutes of life in the preterm babies?
And how are changing the saturation targets? Are they changing saturation targets for
after the delivery room?
After delivery.
Yeah. So based on the so-called NeoProm studies, which were published some years ago now, I think most of us agree that we should keep the saturation target a little bit higher than before. So the European recommendations say that the target should be between 90 and 94%. And we have also added very tight alarm limits, 89 to 95%. The Americans suggest 91 to 95%. It's very similar. But we go for the high saturation target because we know that this decreases mortality. The negative side of that is that by keeping the saturation that high, we increase the risk of severe ROP somewhat. So this is what I call the oxygen dilemma. Whatever we do, we are harming the baby. But we have to choose between two evils, mortality or injury of the eye. Fortunately, it hasn't been shown that high saturation targets lead to more blindness. So that's very good to know.
Okay, thank you. And I'm going to change the topic.
Yeah.
In Gens meeting in Budapest in 2015, you and other clinicians signed an initiative about our responsibility for refugees' children. Do you have any comments about this initiative?
Well, I think the initiative was important, and I'm a little bit proud of it because according to the UN Convention of the Rights of the Children, every child has the right to optimal medical care. And every government except the United States in the world has signed this convention. So I think we want to show the politicians and tell the politicians that they have responsibilities for the refugee children. And I have seen that several other societies have followed up and they made similar statements in 2015. So I think it might have had some impact.
Thank you very much.
Mm.